So really, truly happy to have Dr. Sayan with us, who's a Network Director of Research and Cornea, Cataract and Anterior Segment Surgeon from LV Prasad, Hyderabad. And he's going to be telling us about how to improve outcomes with SLET. On to you, Dr. Sayan.
Thank you so much, Dr. Chitra and Himanshu. I guess I made it just in time.
Yeah.
I'll be quick, just touch upon a few points and maybe just talk about the surgical technique a little bit. So this is what a normal ocular surface looks like. The normal luster appearance of the cornea and, a typical white eye, how the limbus looks like on your top left, what a normal cornea looks like on OCT line scan, and also, what the limbal vessels look like clinically, and also on OCT angiography, you have this typical hairpin loops. These are all features of a healthy ocular surface in an absolutely normal eye. On the photograph on your left, you have a patient with a slightly more pigmented limbus. This is just to highlight that the pigmentation of the limbus does not denote normality or abnormality. These are ethnic variations. You can have somebody with a prominent brown limbus like you have on the left, or a fairly non-pigmented limbus like I showed you before. But what we're trying to look is to identify the palisades and the limbal vessels. So on the right, you see a patient with an inflamed ocular surface. You cannot identify the limbus. You can see that the limbal palisades are stressed, the cornea is vascularized, inflamed, opaque, and this is typically what we refer to as limbal stem cell deficiency. So where the limbus, where the palisades of Vogt reside, where the stem cells are, is distorted, and the normal corneal phenotype, epithelial phenotype is lost, and that is replaced by scar tissue, which is basically what we refer to as a fibrovascular pallus. So when you are faced with a patient with limbal stem cell deficiency, if it is unilateral, this is where we try to look at whether visual acuity is present, and we try to avoid eyes which are dry or have adnexal problems. And in a wet eye without adnexal problems, it's a good eye to, good case to do autologous limbal stem cell transplantation or SLET with or without conjunctival autografting. We usually do not combine it with a penetrating or lamellar keratoplasty because in a lot of cases, SLET itself results in stoma clearing. I'll show you a couple of examples of this. Bilateral LSCD is a much different animal altogether. Here, there are more options because we are more desperate to restore vision to the patient. Not so much in unilateral cases where patient already has a good seeing eye, and therefore the options are a little complicated. You can do allogenic SLET provided the adnexa is normal and the eye is wet. Otherwise, there are different complicated types of keratoprosthesis which can be done. This is not the topic for discussion today, so I'm going to restrict myself to what is on the left of your screen, which is unilateral limbal stem cell deficiency. The first thing, of course, is to make sure that the case that you're selecting for the surgery, as the number one tip for making sure a surgery is successful, is that it is really a case of limbal stem cell deficiency and not a masquerade, because then you'll unnecessarily be doing stem cell transplantation when it's not required. Typically, you can have any chronic inflammatory disease of the cornea or the ocular surface present with vascularization and scarring. It's not necessarily limbal stem cell deficiency. And therefore, we think that the most important objective way of identifying this is OCT. You can just look at a line scan. If you have a hyperreflective epithelium, then that means it's LSCD. If you have a hyporeflective epithelium, it means that it is a patient with a normal cornea, and you're looking at something else. There are, of course, other ways of doing this with confocal microscopy and impression cytology, usually not available. OCT everybody has. So if you are going to choose between the techniques for all practical purposes, SLET is the most practical approach to do. We have a lot of experience with CLED, but right now it's regulated therapy, hardly available anywhere. There are some commercial products available, but in India, if you're looking at, you hardly have any options. SLET basically works fill in the blank technique. You put small bits of limbus and the cornea epithelializes from those bits and covers we have a lot of parallels in dermatology of similar techniques. One is called the Meek technique for treating acute burns, and also there's a very interesting technique for vitiligo, which is on your bottom right, where a similar approach is taken, where small bits of pigmented skin is taken and transplanted in the area which is lost pigmentation. So essentially, you remove the pathological tissue, create a bare sclera and a bare corneal surface, put in the small limbal lenticles from the healthy eye, and then the rest of the cornea epithelializes from that. So there's a lot of evidence in literature to show exactly how this happens. As you can see from the fluorescent stain images on top, epithelium growing out from all these small, tiny bits of limbus, forming islands, those islands then forming large continental masses and then fusing together to form a continuous sheet of epithelium. The same thing can be seen on the OCT scans as well. You don't want to do SLED where you're not sure about the cause of LSCD. It is not a wet eye. The corneal stroma is damaged, and there's a lot of, especially in a case of adenoglaucoma or disorganized anterior segment, the adnexa is damaged. So you want to make sure that the adnexa is treated, whatever entropy or ectropy is taken care of. And the best cases are unilateral, total LSCD, usually with alkali burns and without severe symblepharon. So the OCT also comes in handy, the infrared image and also the line scan, in making sure you are not falling into a trap. So sometimes very thin corneas can look very clear. And at the same time, the infrared image basically tells you what is the relative stromal clarity underneath. You don't want to be operating in a very thick stroma, which may have endothelial dysfunction, etc. So for all these cases, these are all cases of LSCD, but not all are suitable for SLED. Only the ones that you can see on top, where the ocular surface is wet, the lids are normal, but the patient has total LSCD and underlying stroma relatively appears clear. I can see, make out a little bit of the pupil. These are good cases. Whereas the cases at the bottom, where there is entropy on dry surface, etc., these are bad cases. Also, in cases where there's severe symblepharon, you need to combine with a conjunctival autograft, which is your second row. And in the third row, basically shows cases of pseudopterygium or partial LSCD, which can be treated with a conjunctival autograft alone. You really don't need to do SLED in these cases. So I'll just take you briefly through the surgical technique. Unilateral cases, you're looking at the fellow eye. You create a small bleb near the limbus, lift the conjunctival flap. So this is a limbus-based conjunctival flap, dissect down to the limbus, and then take the limbal biopsy. This is the most important part of the surgery, because what you're grafting is going to be the healthy limbus. And so how well the cornea epithelializes depends on how healthy your graft tissue is. So the limbal graft in SLED is as important as the kidney graft in kidney transplantation. And so once you have obtained the limbus, and this is usually without the conjunctiva, we are looking at pure limbal tissue, and then you move to the eye which is damaged. We do a little dissection, remove all this pannus, and sometimes you have to do a combination of blunt and sharp dissection. I'll just move through this. And eventually, when you have a bare ocular surface, first you put down the amniotic membrane, secure it with fibrin glue. You can also put circumferential sutures and secure this with 10 or 9-on. And once the amniotic membrane is, secure, usually you have to make sure that it's nicely put down, and you trim the edges. Then you take the limbal tissue, cut it up. I prefer using a Vanna scissor to cut it into small pieces, usually from 1 clock hour of donor limbal tissue, which is about 3 to 4 millimeters. You can make about 8 to 10 pieces. We put that in the mid-periphery epithelial side up, and then put 1 drop of glue on each piece. The first part, which is the thick part, fibrinogen, and then the thrombin part. Usually when we put the fibrinogen, we spread it out a little bit so that the thrombin, which is more runny, sticks to it when it comes out. And once this is done, that's basically the end of surgery. So it can be completely sutureless surgery, although we do recommend putting nylon sutures for the amniotic membrane for children, and as well as a tarsorrhaphy if required. And this is typically how the surface heals. A normal corneal epithelial phenotype is restored within a few weeks, and this usually lasts forever because it is autologous. There's a lot of evidence in literature to show that the success rates are close to 80%. In recent times, if you now with the evolved knowledge of what the risk factors for problems are, and like I said, if you avoid dry eyes, if you avoid eyes with adnexal problem, your success rate would be between 90 to 100%. Just to show you a few examples, this was a case that I operated in 2011. You can see very inflamed surface, vascularized stroma, even 6 weeks after SLED. But this has continued to improve with improvement in stromal clarity and patient's unaided vision over the course of the next 7-8 years. And this typically happens, and that is why we say that you need to hold your breath for a while and not go in for an early PK. This is obviously, probably the most famous case of SLED or marquee case. A lot of, you may have seen this before, patient presenting with a granuloma, and then 8 years later, the patient with a normal looking eye, and even as severe cases of LSCD like these can be treated very effectively with SLED. Another case with a young boy with Chuna injury, and the same eye 2-3 years down the line, if you saw this child, you'd hardly be able to make out that the child has had surgery. So, we have been working a lot teaching people about SLED all around the world, and it's extremely popular now. And I think there's a lot of evolved knowledge that everybody has, and I think a lot of people can share their personal experiences with it. We have also shown that the limbal transplants retain the stem cells, and that is why you have long-term, surface regeneration with it. And we are looking at also at the biology of how SLED works, especially how allogenic SLED works. Just a couple of things before I finish. One is that the limitations of SLED are, like I said, in partial LSCD pseudopterygium, which is a case on the bottom. You might do a mini clow or a CLAG, which might work. And those with opaque stroma, where you're combining with a LK or PK, I prefer doing a mini clow. And the reason for that is, and these are the two indications where I prefer a clow over a SLED or just a conjunctival autograft. Because the corneal graft, it can have interface vascularization, and a PK is always a high-risk graft. So when you have to repeat the PK, which is quite likely, especially if the patient is young, you don't have to repeat the limbal transplant. If you do a SLED, then you have to repeat the SLED. So that is the only limitation I feel where a clow scores over a CLED. So we know with our combined experience over so many years, or close to a decade or maybe over a decade, and so many people using it, that it's an excellent surgery that gives very predictable results, provided that you keep these pearls in mind and avoid the cases in which not only SLED but any form of limbal transplantation fails, like dry eyes, adnexal problem, etc., where you need to do stem cell transplantation is not the correct approach. You need to look at other alternatives like keratoprosthesis, etc. Thank you so much.
Thank you, Dr. Sain. That was a wonderful talk. Now, supposing you have to do a PK after SLED, what should be your time interval? How long would you wait?
So I think that I would wait several months. Usually the stroma clears quite a lot significantly. And like I said, in unilateral limbal stem cell deficiency, where even the patient, etc., is not as demanding in terms of vision, they're very happy with the cosmesis and usually with the fact that their symptoms are much better and because they can see from the other eye. They are usually quite satisfied with the outcomes, and they don't insist on, like perfect vision, or cosmesis may be an issue. So if the cornea is relatively opaque and, we have not achieved vision as well as cosmesis, that is when I would think about it, probably not before 3 to 6 months of doing SLED.
Supposing you're going to do an allo SLED, what is the kind of immunosuppression you will give and for how long?
So in allo SLED, first of all, case selection is very important. I think the best cases for allo SLED are patients with chronic allergic conjunctivitis who develop a limbal stem cell deficiency because their eyes are wet and they do not have any lid-related problems in terms of entropion, ectropion, lid closure, lag of thalamus, etc. However, the cases that we might be seeing of bilateral LSCD, maybe most commonly patients of Stevens-Johnson syndrome or pemphigoid, these are difficult cases to treat. And therefore, the first thing that I'll say about allo SLED is if you're doing it for bilateral severe allergy or chemical burn, that's a completely different scenario. If you're doing it for an underlying immunological disease, I would say avoid it. Don't do it. Send it to somebody who has more experience because immunosuppression alone will not cut it. But with allergic conjunctivitis and chemical burns, we typically give the patients a combination of steroids and cyclosporin to begin with, oral. And you can maintain these patients very well on oral cyclosporin, steroids and stop.
Okay. Here, Dr. Himanshu.
I think Sain has taken everything. I really don't think anybody can have any question here.
Yeah. Himanshu, I just have one comment. Please, I just wanted to ask Sain. Sain, I think in these cases where you do SLED or you do CLED, more often you have to do a DALC than a PKP. I'm not saying it's not there, it's there, but most of the times the Descemet's membrane is clear in these cases. What do you say to that?
No, I agree. Whenever possible in these cases, you try to do a DALC if the stoma is opaque and you have done SLED and restored the surface, then if possible, then that. PK for endothelial dysfunction also, we tend to do less nowadays. Like I have done, I'm sure you have done, Himanshu, must also have the experience, and I'm sure Dr. Namrata has also done. I've done a few cases where I've done SLED, the corneal clarity has not improved, but I realized that it's because of endothelial dysfunction. And then I've done a DSEK later on. And these patients also tend to do pretty well. So I think it's between DALK and DSEK. I mean, PK, hardly ever.
So one thing about DALK, where I would be a little careful about, and I've burned my fingers there, when you have very bad vascularization, I have had a couple of times where there were sterile melts, and for unknown reason, which I was like not able to explain. And those blood vessels, which, so again, the scarring and vascularization was such that I could not get rid of many of those vessels. And I had two cases where I had sterile melt. And so bad blood vessels, stromal vascularization, something, I would be a little careful there.
Thank you.
Have you seen vessels on the Descemet's membrane growing ever? I don't think. I mean,
yes, I have.
If you leave,
I have.
You leave on the stroma. I mean, if you leave a little bit of stroma, then, but if you do a desmetic DALK, then it's rare to find.
Many times, Dr. Namrata, because of scarring and all those things, it may not be very practical that we get big bubble there, or it may be pre-desmetic. So, well, I would just say that if we are able to get a nice deep stroma, well, that's best, and I would surely endorse that. But just keep in mind that there were quite significant good outcome in these cases. There can be sometimes something like this can happen.
Thank you, Dr.